4172. Today's a real pleasure because we have with us giving grand rounds someone that was recommended by Fred Rickles, who has been our clotting expert here for going on 30 years or longer. But Fred said he didn't feel prepared to do this, but he said he did have somebody at the VA, Dr. Mugnaini, who could do it for us. And it just turns out that Emiliano is one of our former residents at GW. He's been all over the place. He started his career in Williamsburg at Williams College, went to London School of Economics for a year, then went to McGill in Canada for his MD degree, went to University of Oslo for his PhD, and then came to us for his residency in internal medicine. I won't tell you how long ago it was, but you're going to notice a few gray hairs when we see Emiliano, which I like because it makes my gray hair doesn't look so bad. Anyway, after finishing with us, he moved around a little bit. He was in Maine. He was in South Carolina. He was in Vermont, where he was at the University of Vermont with one of my favorite people, Dr. Polly Parsons, who's the chair of medicine in Vermont. He went back to Norway for a while, came back to the United States, and finally, early this year, in January of January of a year ago, 2019, he ended up at the Washington VA, and we're thrilled to have him. It's nice to have him come back to our residency program and our department to give medical grand rounds. I'm thrilled to have him. Emiliano, good to have you back, and thanks for doing this for us. And Emily, go ahead with this first slide.
Hello, everybody. Thank you very much, Dr. Wasserman. It's a real pleasure for me to do this, being a graduate of GW. Just a quick question. Was there an update by Dr. Axelrod first? Or?
No, we decided that things have calmed down, and let's hope it stays that way. And we've stopped the weekly updates, and we'll see. We'll bring them back if we need to, but let's hope the DC stays calm.
Great. Okay, that gives me a little more time. So this is a very active topic. I've titled these slides "Hypercoagulability in COVID-19 and Inflammatory Coagulopathy." Quick disclaimer: I am not what we call in hematology a clotter, but I have worked with people who are quite expert in thrombosis and hemostasis in Vermont, as you mentioned. Very active group with Chris Holmes and Mary Cushman and Neil Zakai. And then here with Dr. Rickles. Another second disclaimer that this is a moving target. Information is coming out weekly, and we're all grappling with what to do on the hemostasis front or the hypercoagulability front in COVID. So could you advance the slides? I'll just keep saying next then. So the outline today, we'll look at normal coagulation homeostasis, then disease course and lab results in COVID. We'll focus on inflammatory coagulopathy and a fair amount of microscopic findings. And then lastly, hematologic management of hypercoagulability in COVID. And that's really why I got into this. We're trying at the VA to find out what to do with these patients who are having a lot of clotting issues. Next. So the objectives, a little bit of a repetition, a review of physiology of clotting, number one. Number two, understand that inflammatory markers rise during the disease course, and we'll see some kinetics and dynamics there. Number three, recognize the high incidence of vascular events in COVID-19. That's why we're talking today. Four, appreciate the prominence of platelets and fibrin deposition in tissues. And this is something that's come out more and more as the pandemic has moved towards this area of the world. It turns out in Asia, just genetically, I'm presuming they don't have, not that they haven't had hypercoagulability in COVID, but they are less hypercoagulable Asian population than Western populations. And then number 5, so that as the disease has moved here, we've seen these things manifest themselves more and more. Number 5, we're getting more and more evidence of direct viral infection, which is resulting in an endotheliitis, which is widespread throughout the body, and that's really creating buzz lately. And number 6, which is why I was pulled into this, trying to come up with a management strategy, and we have decided on the side of being proactive in anticoagulation, believing this may be of benefit, although the data is really lacking, but we have to do something in the meantime. Next. Okay, so the homeostasis, try to go quickly. Human homeostatic system provides a balance between procoagulant and anticoagulant forces. This allows for normal blood flow, but also clotting to prevent exsanguination following an injury. The players in the system are number 1, platelets, number 2, plasma proteins, clotting factors, and inhibitors, and number 3, of course, the vessel wall. So procoagulant forces being platelet adhesion, platelet aggregation, and fibrin clot formation, anticoagulant forces being inhibitory proteins and fibrinolysis. And the figure is an original by me, made for you. Next, please. So when we have vascular injury, platelets adhere to a denuded vascular intimal surface, primarily to von Willebrand factor, and also to subendothelial collagen. We get platelet adhesion, resulting in activation and aggregation. We see the prominent role of platelet glycoprotein 2B3A, which is the most abundant receptor on the platelet surface. And that platelet activation converts the inactive GP2B3A to the active GP2B3A form. Platelets further bind von Willebrand factor and fibrinogen in the loop, and fibrinogen bridges form between platelets with further platelet interaction, including even more platelets. Responses are enhanced or amplified by epinephrine, thrombin, ADP, and serotonin, and the resultant platelet plug anchors to a fibrin mesh, forming a platelet thrombus. Next. Next slide, please. So here's a figure from Harrison's. We see inactive platelets and active platelets that are, so the inactive become active as they bind collagen and expose von Willebrand factor. So already here we see the importance of a endothelial injury. And then 2B3A receptor binding fibrinogen and fibrinogen bridges are displayed as well. Next, please. So this is a coagulation cascade slide. Many of us have seen these before. Purpose is not necessarily just to remind you of medical school, but to walk quickly through it. We have on one side of the screen the intrinsic pathway, and the other side the extrinsic pathway, culminating or joining in the common pathway. Not sure whether you see my pointer. I guess not, since I'm not running the slides, but that's okay. So we march through this with known factors on the intrinsic pathway, which determines the PTT. We go from 12, 11, 9, and then with the help of 8 to 10 to 10A, 10A being the crux of the figure, the fulcrum. You can also get to 10A from the other side, the extrinsic pathway, running through factor 7 as the lone factor there with interaction with the tissue factor, and then 7 feeds into, in an augmenting fashion, to the left side of the picture at the factor 9 level. And going back to the common point, then 10A, with the help of 5A, converts prothrombin to thrombin. Thrombin then converts fibrinogen to fibrin, and cross-linking of fibrin occurs with the help of protein. That's probably good enough for that. However, one more thing, just have a little image of that. So the left side, the intrinsic pathway, there's a contact phase with that PK prekallikrein and HMWH, high molecular weight, and the extrinsic pathway on the right, 7A and tissue factor. We're going to come back to those as we talk about therapeutics. Again, the contact phase on the left and the tissue factor on the right. Neutrophils and complement can interact with the tissue factor as part of an interface between the innate system and the coagulation pathway. So next slide. Here again is the same recapitulated. We have vessel injury, we have tissue factor and 7A interacting, leading on the left via 10A, and this also feeds in and augments the intrinsic pathway. Here are the slides, or the sides of the equation, left and right, as we pick up are reversed. So the right side of the screen showing then the intrinsic pathway looping through 11, 9, and to 10 from that side. And then again, culminating in fibrin into fibrin. Next, please. So COVID-2, severe acute respiratory virus 2, a beta coronavirus, giving the disease coronavirus disease, 2019. I know that the GW Department of Medicine has been doing a phenomenal job with updates here, so I don't want to go. We'll go through the next slides quickly. Next, please. COVID characterized by interstitial pneumonitis. Top figure CT scan on day 7 of a typical patient, and then bottom half of the figure day 14. Clearly, we see a progression of disease, and this is the typical disease course that patients are getting worse in the second week, often after hospitalization. Next, please. Just quickly, some of the first series of patients and numbers out of China, 3 studies, New England Journal of Medicine with 1,000 patients, and then the JAMA study with 138, and the Lancet study with 191. These are clinical characteristics of hospitalized patients from the early phases of the pandemic in China. Next. And so these are just those 3 articles kind of tabulated side to side. Top half of the screen, top portion of the screen is characteristics on admission. There's an asterisk if they were associated statistically with poor outcome. And then below the line, just to give a little bit of a feel for how sick these patients were, the percentage of patients, again, all hospital patients that were in the ICU and ultimately during the study period died. Common comorbidities, hypertension, diabetes, coronary artery disease, we know this. Another large series from New York with, I think it was about 3,000 patients in Lancet, also correlated statistically with obesity. And then the presenting symptoms, cough, fever, fatigue, sputum, shortness of breath. If we look at just the New England Journal one on the left side, fever initially 44%, but then 89% during hospitalization. So again, patients getting worse after they show up to the hospital. Next, please. And so looking a little bit more at the kind of hematologic characteristics primarily, we do see some leukocytosis. And one of the main things that caught people's attention was, however, low lymphocyte counts, lymphocytopenia, prominent in a significant number of patients. And also see thrombocytopenia, but that's much less prominent than in other acute illnesses. What we do get is an elevation in inflammatory markers, high CRP, D-dimer, ferritin, LDH. We're particularly attentive to D-dimer, which has a prognostic implication. High D-dimer obviously bad. And you can see in terms of coagulopathy, some prolongation of the PT. PTT also, although less, and these prolongations are less prominent than in other acute illnesses. And we'll mention a little bit about that in the future. And then chest X-ray and CT findings abnormal. Next, please. So these articles, what I like about them is they show us here the dynamics of the infection during the hospital course. And contrary to many medical admissions where patients come in looking bad in extremis, you give them, let's say, antibiotics and effervesce, and all the curves are down going. Here with COVID, it's the reverse. They come in, they have their symptoms, whatever that baseline may be, and then the ones that do worse do progressively worse while they're under your care. Obviously very frightening to experience as the caregiver. So we see over time white blood cell going up, neutrophil count going up, lymphocytes going further down, D-dimers coming up late, and then kind of in the late phases, renal abnormalities, EO and creatinine. Next, please. Another picture of more or less the same dynamic, D-dimer really escalating in non-survivors, lymphocytes falling, IL-6, important cytokine, rising as things get worse, serum ferritin likewise, and troponin in the very last days, and LDH kind of progressively all the way along. Next, please. So what we're seeing then is a highly inflammatory coagulopathic clinical pathologic state. The ZOO authors postulated age-dependent effects in T and B cell function and excess production of type 2 cytokines could lead to deficiency and control of viral replication and more prolonged pro-inflammatory response, possibly leading to poor outcome. So those were the kind of initial takes on the dynamics of the infection, but we've learned much, much more, and we'll see that. And all of what they're saying makes sense, but there's just, we're getting more specific on this as our understanding advances. Next, please. So being hematologists, do abnormal coagulation parameters associate? We saw them rise over time in the non-survivors, and here we're seeing them associated with poor prognosis. So this was a study by Tang et al. With 191 patients that tracked coagulation parameters from day 1 through day 14 after admission and looked at consecutive patients. What they underline in their findings is abnormal coagulation results associated with poor prognosis. And they talk about DIC being common in deaths with COVID. We have to kind of be a little bit careful when talking about DIC in COVID. What the coagulopathy we're seeing is not your classical DIC. So if you want to define DIC by established international criteria, often you can qualify for DIC in COVID right at the end. But in that longer progressive several week state of hospital stay, these patients are not necessarily in DIC. They're coagulopathic, but their PT and PTT are not changing all that much. Their platelet count is not falling all that much, and we're not seeing the microangiopathic hemolysis that we do in DIC. When you look at a smear of a DIC patient in the ICU, you should see a lot of schistocytes. We don't see that many. We see some, obviously. COVID patients are ill, but it's not prominent. So just the key word there is DIC common in deaths. In my opinion, it's really just a last phase, something akin to an internal medicine ICU admission where, yes, the kidneys fail, but that's just after a long illness, but that's really just the terminal phase. So next slide, please. Here, again, abnormal coagulation parameters result in poor prognosis. If we just look at the D-dimer with a p-value of less than 0.001, much higher in non-survivors than survivors. That's point number 1. Point number 2, next slide. Okay, sorry, before getting to point number 2, tracking these dynamically again over time. PT does rise a bit during the course of hospital stay. So we see days of admission and the PT level there on the top. PTT doesn't fluctuate as much, D-dimer rises and really gets jacked up right at the end when things are going sour. Also the fibrin degradation products. And then notably, the fibrinogen is high as an inflammatory marker for most of their hospital stay. And then only when they start to get really bad and we're losing them does the fibrinogen fall. And that's when they're qualifying as DIC in the traditional sense. But it's not really a driver of the hospital stay and the clinical pathologic progression. And then the last one shows antithrombin, which can be low. Next slide, please. So their point number 2 in this article, DIC is common in death, again, just at the death stage. So if you go down to the last line, there were 21 patients and 15 met DIC. This is only non-survivors. 15 of the 21 non-survivors, or 71%, fulfilled ISTH, the International Society of Thrombosis and Hemostasis criteria for DIC. On the contrary, in the text to the right, only 0.6% of survivors match the DIC criteria. So if you do get to that end DIC stage, that's bad. Next. So we're also just recently, this is published online, hasn't appeared in press. This is coming out of the group at Yale with Alfred Lee and Henry Rinder and friends. And they're also looking at parameters over time during the course of infection. And we'll mention a little bit more of this as we move on to talk, just in the course of, I put it here because we're tracking now these changes through the course of infection. And this study measures soluble P-selectin, which is a marker of endothelial cell and platelet activation, soluble CD40 ligand, which is a marker of platelet and T-cell activation, and soluble thrombomodulin, which is a transmembrane endothelial product, a glycoprotein rather, that is released as endothelial cells are activated and damaged. And they looked at the Yale New Haven Hospital 40 ICU patients with COVID compared to 10 non-ICU or ward medical floor patients, and then used 13 non-COVID, non-hospitalized normal controls. Next, please. And so what they're seeing, soluble P-selectin, we're looking at then the levels. We see in the darker color, a kind of a green-gray of the controls, and then we see the blue, the non-ICU COVID patients, and the red, the ICU COVID patients, with corresponding p-values. Just appreciating the trend, more P-selectin in the ICU, looking at soluble CD40 ligand, more of that detectable in COVID patients in general, both non-ICU and ICU. Again, that's a platelet-related marker, so maybe when we think about treatment, if we're thinking about what to do with the ward patients, maybe we should start thinking about something to do with the platelets. And then the bottom shows us soluble thrombomodulin, again, getting elevated as the level of illness escalates from non-ICU to ICU level. Next, please, at least tendency. And what they did, significant finding they did report was soluble thrombomodulin is now being launched as a marker for prognosis. We already know that D-dimer is prognostic, and now we're know, thanks to this report, it's soluble thrombomodulin, which again is released by endothelial cell injury. So diffuse endothelial cell injury is happening, and it's bad. We can see that it correlates with survival probability, both in all patients and in ICU patients. Next, please. So this talks about hypercoagulability in COVID. Yes, we know there is a lot of there are a lot of vascular events, both on the venous and the arterial side. So we're talking about venous clots, arterial thromboses, MIs, strokes, and with the venous side, both DVTs and PEs, obviously. And so there are many reports of how many VTEs do occur in COVID. This is just one of them. At the bottom, it's showing us a 69% rate. That's the highest quoted rate. Other Dutch studies, this is a French study. Other Dutch studies are more around the 25% mark, but this is kind of the highest number, so it's the most dramatic. That's why I put this in here. What they did, they looked retrospectively at consecutive patients in 2 French ICUs. And then what I liked about it, although it's perhaps not a great paper, what I do like about it is they did baseline bilateral lower extremity ultrasounds within the first 3 days of admission to the ICU. And then the MDs managing the patients either had the patients on prophylactic or therapeutic ventilation for whatever reasons they might have had at the time. And then they went back and they rechecked in all these consecutive patients a repeat bilateral lower extremity ultrasound after 7 days, and or a CT chest or echo if there were concerns for the lungs. And in the patients who had prophylactic anticoagulations, 100% had VTEs. And in the therapeutic group, 10 of 18, or 56%, had a VTE event. And so even a therapeutic anticoagulation will not save these patients. We do think it helps them, but we don't have great evidence for that. It's really just an assumption. There is one piece of literature evidence that we'll get to towards the end. Next, please. So I'll try to pick up the pace here. Pulmonary and cardiac pathology. This is autopsy series from New Orleans, 10 patients, cause of death attributed to COVID. They looked at relevant cardiopulmonary findings. There wasn't a significant degree of secondary pulmonary infection, so these changes were presumed due to COVID. The cardiac findings, just very briefly, dilated ventricle. There was myocardial cell necrosis without lymphocytic myocarditis, and in these patients, no coronary artery stenosis or thrombi. Next, please. What they describe mostly in the article is the lung changes. And so here we're going to see again in several studies that what is happening in the lungs in COVID is quite unique. When you compare to ARDS, there is overlap. COVID changes are perhaps a subset of ARDS, but it's not the classic ARDS. The distinctions are more and more prominent. There's a discussion of this, I think, print version of the New England Journal this week. A lot of this is lung pathology, is not necessarily my expertise, but in any case, what they report in this article from New Orleans, their 10 autopsies, lungs are heavier, bronchial pink froth, there's serosanguinous effusions, and the perfume is diffusely edematous and firm. All that is consistent with normal ARDS. And then they're also in the periphery focal regions of dark hemorrhage. And then after fixation, the cut surfaces have alternating tan gray consolidation of hemorrhage areas up to 6 centimeters, quite significant hemorrhage areas, although bleeding in general is not anything very common. And then there were in the periphery small firm thrombi. And this was reported as a finding, these microthrombi in the periphery early on from China as well. Next, please. So they report different patterns of alveolar damage. A phase 1 they propose is an early oxidative phase with edema and hyaline membrane formation, more typical of ARDS changes. Then there's a phase 2 proliferative phase and a phase 3 fibrotic phase, which is more typical of COVID, more specific to COVID. Next, please. Looking close up, figure A, large pneumocytes, damaged alveoli, and figure E, electron microscopy suggests that some of that carnage is due to viral infections. Infection in the lung. Next, please. And they see infiltrates of CD4 and CD8 cells, although these are not massive infiltrates. What is there is located in the interstitial spaces and around larger molecules of blood vessels. And kind of the more remarkable part of their observation is that the alveolar capillaries are thickened with surrounding edema, and they were able to show us thrombi and platelets contained in these capillaries. So we see the arrows, a thrombus in the small pulmonary artery, green arrow, and in an adjacent pulmonary venule, head, and then immunochemical staining of CD61, highlighting the thrombi. Next, please. And what they found, also quite remarkably, is the presence of lung lung megakaryocytes, CD61 positive pulmonary resident megakaryocytes that had nuclear hyperchromasia and atypica. So B shows the megakaryocytes. The hematology fellows, if they're any listening, can recognize megakaryocytes from they look in that picture just like they look in a bone marrow aspirate. This is not the bone marrow, this is the lung. And then C shows us the CD61 stain again, showing fibrin and thrombus in a small vessel. The karyocytes were located within alveolar capillaries and could be seen actively producing platelets. Quite fascinating, actually. And with this aggregation of fibrin and platelets, there were some inflammatory cells with entrapment of neutrophils. So already here in the pathology, we're seeing an interplay between neutrophils and platelets, innate immune first-line defense with coagulopathy. And in this series, the thrombi were mostly just in the lungs. Next, please. So they describe a thrombotic process that may involve activation of megakaryocytes, possibly native to the lung, platelet aggregation, and platelet clot formation, in addition to fibrin deposition, with corresponding implications for possible treatment. Next, please. This is stolen a screenshot from Dr. Axelrod. There's new evidence of hyperactive platelets in COVID. I won't go into detail. But that evidence, expect more and more studies. Next, please. And then we're begging the question, does, in addition to seeing SARS-CoV-2 in the pulmonary pathology, does it directly infect endothelial cells? So this was a Lancet article showing endothelial cell infection and the phrase endotheliitis in COVID. We know that the host is infected through the ACE2 receptor, which is expressed on various tissues, and also, importantly, on endothelial cells. And the question here is, are vascular derangements caused by endothelial cell infection by the virus? The New England article this week also looks at that in lungs. Here, they're, in contrast perhaps to the last autopsy study, here they're showing it in different organs in addition to the lungs. Next, please. So they show us direct viral infections of endothelial cells and diffuse endothelial inflammation, lungs, heart, kidney, small bowel, liver. The kidney is pictured in A. Magnification of the electron microscopy shows us the viral particles. And then in C, we're looking at small bowel with some mononuclear cells, not fulminant mononuclear cells, but they are there. And the stain is for caspase A3, showing apoptosis. And D is the lungs, again, showing us arterial vessel involvement with inflammatory cells and apoptosis of endothelium. Next, please. Next slide. So they write an ode to the vascular endothelium. This is coming out more and more. We already looked at the Yale study that is in preprint form, showing the systemic endotheliitis and correlating that to outcome. But what they write is vascular endothelium is an active paracrine endocrine nautical organ that is indispensable for the regulation of vascular tone and the maintenance microvascular homeostasis, whereas endothelial dysfunction is a principal determinant of microvascular dysfunction by shifting the vascular equilibrium towards more vasoconstriction, subsequent organ ischemia, inflammation, and associated tissue edema, and a procoagulant state if we have endothelial dysfunction. So COVID-19 endotheliitis, therefore, could explain the systemic impaired microcirculatory function with different vascular beds all over the body and the clinical sequelae for patients with COVID. And again, this provides a rationale for therapies. Next slide, please. Just a quick note, in looking at the vasculature, there are studies showing the role of complement. If we think back to that first slide with the coagulation pathways, complement and neutrophils interact with tissue factor, the extrinsic pathway. So this study shows that complement deposition together with virus may be pathogenic, at least in a subset of patients. And so this is a report of 5 cases, only 5 cases, but very thought-provoking. They looked at skin and lung tissue in severe respiratory failure and often with skin involvement in the same patients. And they described a COVID-19 pneumonitis as pauci-inflammatory septal capillary injury with significant septal capillary neural and luminal fibrin deposition. They did not observe viral cytopathic changes themselves, although they may be there. And they do note the distinction with, although there's overlap here, but the hallmarks of classic ARDS with diffuse alveolar damage with hyaline membranes, inflammation, and type 2 pneumocyte hyperplasia was not prominent in these patients. Next, please. So the pulmonary findings were accompanied by significant deposits in the microvasculature. They showed us terminal complement components, CD5B to 9 membrane attack complex, the CD4D, and the nanospining lectin MBL associated MASP2 staining, both in the lungs and similar findings in the skin. And importantly, they co-localized these things with COVID-19 glycoproteins. So they conclude that at least in a subset of sustained severe COVID-19, a type of catastrophic microvascular injury syndrome may be mediated by complement. And so this is one of our kind of deeper levels of understanding of what's going on in some patients. We can touch more on it later if we have time. Next. This is some of their pictures. I'm going to skip this one. Just shows us pulmonary involvement in HED stains. We kind of talked about that. And here is immunohistochemistry. So A, they're showing us CD4D deposition. B, a higher magnification of the same CD4D. And then C shows us the MAC, the CD5B to 9 deposition. And then also CD3D staining in the D sub picture. Next, please. And they co-localize these things. It comes out better in the next slide, please. So here, this is for the CD5B to 9 reagents. The immunohistochemistry is repeated in E, and then F shows C5b9 in green, and the G shows us CoV2 alone, and then which is so green in F, red in G, and then H shows them co-localized in yellow, CD5b9 plus SARS-CoV co-localization, so complement involvement in the lungs, illustrated by that study. Next, please. So they postulate, and this is perhaps something more for pulmonologists to go deeper into than myself, but they write that our histologic findings are consistent with emerging observations suggesting that COVID-19 has clinical features distinct from typical ARDS. And this is the story that we were hearing in New York when this was first raging by intensivists who talked to us about patients who were severely hypoxic yet compliant and talking on their cell phones. Ultimately, however, as disease course deteriorated, requiring intubation. So they write, that is, COVID-19 related severe respiratory distress can be manifest by relatively well-preserved lung mechanics, despite the severity of hypoxemia characterized by high respiratory compliance, high shunt fraction, and prolonged requirement for mechanical ventilation. Pathology in these cases might therefore be expected to differ from the diffuse alveolar damage and hyaline membrane formation, which are hallmarks of typical ARDS. Albeit preliminary pathology studies of lungs from COVID-19 cases described diffuse alveolar damage with edema, hyaline membranes, and inflammation, followed by type 2 pneumocytoplasia, features characteristic of typical ARDS. The pulmonary abnormalities in our patients appear largely restricted to the alveolar capillaries, that is, more of a thrombotic microvascular injury, the peripheral microthrombi, rather than the diffuse edema of ARDS, with few signs of viral, relatively few signs of viral, cytopathic, or fibroproliferative changes. An increase in the dead space fraction might be anticipated with this type of pathology, i.e. respiratory failure, greater lung compartments, and less pulmonary consolidation, and is characteristic of typical ARDS. Next, please. So there is something unique about COVID. This is an article, I think also, no, I guess it's in print now. This is from May or earlier June, with a number of coagulopathy experts here. And they are postulating that the coagulopathy in COVID is totally unique. It's related to classic coagulopathy that we are familiar with as hematologists and internists from other diseases, but something is different about COVID. And we can go to the next. So they talk about COVID-19 coagulopathy in the middle, intersecting with our other traditional pathogenic mechanisms of sepsis-induced coagulopathy or diffuse DIC, disseminated intravascular coagulation, or on the right, HPS, hemophagocytic syndrome, or on the bottom, antiphospholipid syndrome, or on the left, TMA, tissue microangiopathy. So it's stealing features from each of those known mechanisms, but yet doesn't completely fit any of them and seems to be something different. And in the coming weeks and months, we're sure to learn more about this. Next. Some of the implicated players that could give an explanation to what's going on in COVID coagulopathy include PAMPs. This is the innate interaction. So this figure comes from a review article looking at bacterial infection. Here, obviously, we're talking about viral COVID. But some of the players implicated in COVID coagulopathy, the basic science is just coming out of publication now, are listed in this figure. And they include innate immune system associated or recognized PAMPs, pathogen-associated molecular patterns. We see that on the left under the sepsis. Also, polyphosphates, the poly-P there. And then these nets, neutrophil nets on the bottom. Next slide, please. These are all part of a contact pathway, which may show us that everything is wrapped together, because the contact pathway, which is on the left side of that initial figure where we looked at the clotting mechanisms, the intrinsic side of that figure, interacting with factors 12 and 11, also free kallikrein. And the reason why contact pathway may explain the coagulopathy here is that it's a way we're seeing linking of both inflammatory and coagulation phenomena. Next, please. So what to do with these patients, which is really why I had to look at this. we don't know. This is an area of hot debate. There are multiple randomized trials going on. Patients we saw from the French data are clotting despite full dose anticoagulation. What we're trying to do is decide how to manage them. Do we just increase the dose of anticoagulants? Do we give them antiplatelet agents? Do we use things that are directed to the endothelial damage or the innate immune system? All of these approaches will be discovered. Right now, we've kind of focused on what dose of anticoagulant to give. It's the simplest question. And somewhat remarkable or maybe disappointing, the societies are being very conservative, whereas single institutions are establishing their own more aggressive protocols. So as of today, the American Society of Hematology tells us that all hospital patients with COVID should receive pharmacologic thromboprophylaxis with low molecular weight heparin over unfractionated heparin, just to reduce contact, unless the risk of contact with the patient and contagion, unless the risk of bleeding outweighs the risk of thrombosis. That's nice, but it's not all that different from what we do with internal medicine patients in general, hospitalized patients. And then whether critically ill COVID-19 patients should receive therapeutic intensive anticoagulation in the absence of confirmed or suspected VTE is currently unknown. Multiple randomized controlled trials are underway. Patients hospitalized for acute medical illness are at increased risk for VTE for up to 90 days after discharge. Therefore, it is reasonable to consider extended thromboprophylaxis after discharge using a regulatory approved regimen, such as rivaroxaban. That should, I think, say 31 to 39 days, actually. So we started off at the VA here in Washington, thinking that, well, we're not really in a position to break ground off of a clinical trial, so we'll just follow the society guidelines. But patients are clotting even through not just prophylactic doses of anticoagulation, but therapeutic doses. And so the appeal, and this is mentioned in a number of the articles that quantify the VTE rate in COVID-19, is to use higher doses of anticoagulation and use them perhaps earlier. So we were grappling with this. We decided we needed a institutional protocol. Also, the intensivists were begging us for that. And so we looked at this together with my colleagues and kind of vetted many different algorithms from other institutions, from Mount Sinai, from Mexico, Carolina, Emory, Michigan, many places. And while we were designing our products, our algorithm, agreeing on our algorithm, and again, I'd like to thank my colleague Dalia Barak for her vast contact network in gaining all those protocols in various institutions that are not necessarily published. We were vetting these things. And while we were doing this, a publication came out, which has been cited, and that's the next slide. And this came out of Mount Sinai. It is simply a letter, but it is from the eye of the storm. The N, the 2,773 patients, certainly catches your attention. It's limited in the fact that it's a single institution retrospective study of hospitalized patients. And its purpose is to examine the effect of full dose anticoagulation, which is something we wanted to do for these patients. And this was at a time when our intensivists were really being more aggressive with the patients because they saw they were clotting. There were strokes, there were catastrophic outcomes in our hands. And so we wanted to do more. And this study looked back retrospectively at Mount Sinai and saw who had had any time on treatment dose systemic anticoagulation, which was 28% of their patients, versus who had had no treatment with systemic treatment dose anticoagulation, i.e. just prophylactic dose. what they found was remarkable. Next. So they look at survival probability. The red is no therapeutic anticoagulation during hospital stay. The blue is full dose anticoagulation during hospital stay. And they're showing us graphs for all patients on the left and patients on the right requiring mechanical ventilation. There they have 395 patients requiring mechanical ventilation. And if we go to the bottom, they see that if you got mechanical ventilation, your mortality at the end of their study was 29% compared to 63% if you didn't receive full dose anticoagulation amongst mechanical ventilated patients. This really pushed us to just take the plunge and put everyone in our ICU, unless we had specific contraindications, on full dose anticoagulation. Flimsy data, but we have to work with what we have. Next study, next slide. And we felt relatively good about doing this because even in the ICU, although there were fears that we could get more bleeding, statistically at Mount Sinai, that doesn't seem to have been the case. There were 1.9% of bleeding events, and they're defined above, 11 less than 7, 2 units PRBC transfusion, or major diagnosis code. If you didn't get systemic anticoagulation, 1.9% had a bleeding event during your stay, versus a little bit more, 3%, if you did get full dose anticoagulation, but at a non-significant p-value. So that made us feel relatively good in being proactive. And as we said, there are ongoing randomized trials testing whether this is going to play out. Next, please. So this is kind of a short form of what we're doing at the VA. If you're a floor patient, we're putting you not just on standard low molecular weight prophylaxis, which would be something like enoxaparin 40 once a day, but we're putting, unless you have specific criteria defined by obesity or low body weight or renal function, we're putting our floor patients on intermediate dose, higher dose prophylaxis, meaning most of them on enoxaparin 40 twice a day. And then we're putting and there are some footnotes there if the counts are very low, or there are severe abnormalities in the other numbers. Those are in the footnotes. But for your basic ICU patient, we're putting everyone on full dose therapeutic anticoagulation, which is usually enoxaparin, one mg BID, or and this is essentially copying the Sinai algorithm. Other institutions are using D-dimer as a guide. That's not specific, so we didn't like it. And then there are other variations, and there are many who are not really doing full dose therapeutic anticoagulation unless the patient has a documented VTE event. Then they're going mostly to therapeutic. But here we are just, if you get into the ICU with COVID, we have you on full dose anticoagulation. And the thought for the floor patients is that we can get things at the bottom. Next slide. My own version of the slide set actually has a couple more things, but I only have 2 minutes, so I'll just say that's it and answer any questions in the remaining time.
Great. Thanks, Emiliano. That unfortunately probably leaves more questions than answers, but at least we're working through this. So I guess anybody could really tiger text me some questions. People have already tiger texted me some questions. One of them is there any role for ACE inhibitors to try to stabilize the endothelium?
Yes, I mean, that's one of the endothelial tactics, and I think these things are being tried now, but I don't have those results to specifically recommend. I would guess that that is something we want to do early. I think that as we learn more and more, we'll be doing more pre-hospitalization. Just like our algorithm has the floor patients on intermediate dose rather than regular dose, when the patients are at home tested positive but not meeting criteria for admission, I think studies will begin to show us that we should do more with those.
No.
There are some randomized trials going on.
In addition to, if anybody has a question, please Tiger text me or do the chat room. Please don't talk. Are we targeting any other pathways, complement platelets? You didn't mention putting people on, clopidogrel or even giving them 2B3 inhibitors.
Right. I think that's coming. They're in trials. The aspirin is kind of the low-lying fruit, to my knowledge, that hasn't really proven a benefit. But I think that some people are taking aspirin, and there are trials with 2B3A. There are trials with eculizumab along with complement.
So there's some questions on the chat that are interesting. Do you think the reason the low molecular heparin works is because the anti-complement effect? And therefore, do you need a high dose?
So we know that there's an anti-inflammatory effect of all heparin products. There's also a purported antiviral effect. I don't think I can comment on the anti-complement effect.
And along with that, are we seeing this in any other systemic inflammatory conditions like lupus flares, ulcerative colitis? Are we seeing anything like this before?
I mean, what they're talking about now is this is really a unique coagulopathy, and they're calling it CAC, COVID-19 associated coagulopathy. It sounds more like cacophony right now, but.
Well, so what about people that are immunosuppressed? You would think that they wouldn't have this cascade, but yet we think they're at higher risk.
Yeah, there have been some people looked at immunosuppressed patients. I think all in all, they just kind of turn out the same.
So Dr. Gomberg,
with that.
Marty, do you want to ask that question? I don't think I can understand what you said. Why don't you ask it? I don't know if you can unmute and ask your question about pulmonary hypertension. I think you're saying in the lungs, it looks like, pulmonary hypertension. And Dr. Shamugan also asked, so for therapies for pulmonary hypertension, have that been tried? And nitrous oxide inhalation, has that been tried?
Yeah, I think these are ongoing strategies. Obviously, the more invasive something is the harder it's going to be to apply to a large number of people. They're working on all of these things. I mean, as the appreciation for this systemic endotheliitis grows, we're just begging the use of other agents. We did we took the low-lying fruit first. These patients have a lot of clots. How do we treat clots in internal medicine? We put them on blood thinners. So what was the first thing we can do with these patients is just up the dose. But first of all, that doesn't always take care of it. And there seems to be much more at play here.
Yeah, so
interaction with the endothelium, the innate immune system, the platelets that are hyperactive. There's just a lot of, it's kind of a multi-factorial hyperactivity here. So.
Okay, so Dr. Gomberg is on. Marty, go ahead.
Yeah, so the lungs of COVID patients look exactly like pulmonary vascular disease, PAH, and we've been targeting just the anticoagulation, which is how the field of PAH started, with Valentin Fuster, who's on that letter, talking about anticoagulation because of the microthrombi in the pulmonary vasculature. But all of our anticoagulation is not really targeting any of the endothelium or the smooth muscle cell reactions. And so our PAH therapies might actually work in this. I know there's an NO trial that's ongoing for this, but NO is more just for the vasodilatory aspect of it. And I don't think it's going to repair the endothelium. And I think that we need to start targeting all the different processes with the PAH therapies. And so the problem is that most of our therapies cannot be given by mouth through the ET tubes in the really sick ones, but it might be worthwhile looking at in less sick patients. But my concern was, which I didn't see in your pathology specimens, if it affected the pulmonary venules, because if the venules are also affected, then all of our pH therapies won't work because they'll go into florid pulmonary edema when you start to vasodilate and affect the endothelium. Do you know if it affects the venules?
You may be going beyond my knowledge of pulmonary
Scope of
pathology.
pH. Okay.
However, I'm going to say yes, that it's getting both the arterial and venule side of the lungs.
So the rheumatologists are going to like this, but shouldn't the treatment be geared to the systemic inflammatory condition? I mean, if you stop that, you should be able to stop everything, right?
I think that that's, you know, this hyperactivity is kind of a self-perpetuating loop, but I kind of see us going more in the direction of the endothelium. It seems as if what is unique about CAC, COVID-19 associated coagulopathy, is something with the innate immune system interaction with the endothelium. And that is when we get into the systemic worsening of multi-organ involvement, that seems to be where the problem arises. And then, yes, that triggers a cytokine storm, but it's kind of like DIC, where this is just a secondary event in a later stage of the disease course. But the problems, I think we've got to intervene earlier. And to me, the key that is emerging is the endothelium.
And what are you sending people home on right now?
We're sending them home on a little bit of an extended dose of anticoagulant just as things cool down. I don't know that. So we're sending them home on 14 days of injections of low molecular weight heparin. As was on the American Society of Hematology slide, another option is 30 days or so of a dose-active rivaroxaban, for example.
Right, which is a lot easier on the patient.
But there is, so another thing I should say is that I showed you that there's a lot more VTE in COVID than other illnesses, and the VTE is mostly occurring in the ICU setting. The rate of VTU in the ICU setting in COVID is 7 times the rate on the medical floors. But that being said, we are also seeing some VTE events, i.e. people go home and come back.
Well, look, this is an ongoing process for everything, and we're going to be here about renal disease next week, and I'm sure we're going to be hearing the same thing, that we're just learning and we don't know exactly what to do. Emiliano, thanks for doing this. Thanks for being back in town. Look forward to having more of these conversations with you, and thank everybody. We'll see you next week.
Thank you very much. It's been a pleasure.